What's up, AP Psych? Welcome back. We are moving on to the psychological therapies part of our mental disorders and therapies unit. We're almost finished up. We've gone over 30 different types of psychological disorders, and now we're going to get into the various ways that they try to treat those disorders to improve people's lives. So, the therapies that we're going to focus on. There's psychotherapy, which involves an emotionally charged, confiding interaction between a trained therapist and a mental patient. That's the classic therapy you think of, the interpersonal therapy. Then you have biomedical therapy, which uses drugs or other procedures that act on the patient's nervous system, curing them of psychological disorders. And you have eclectic therapy, or the eclectic approach, which is various forms. You could use different types of psychotherapy together, or you could use a type of psychotherapy mixed with a biomedical therapy. This is the most common because it depends on the client's unique problems and they can tailor the therapy to them instead of just relying on one specific therapy. So those are the three different types. And now we're going to hop into the perspectives. So this takes us all the way back to Unit 1 when we talked about the perspectives of psychology. So none of this information should be new to you. And if you think about the ways that psychoanalytic, humanist, behavioral, and cognitive psychologists, their outlook on human psychology in general, it will help you understand their outlook on therapy. So we're going to look at these four major areas and dive in. First, psychoanalysis, classic Sigmund Freud, right? The first formal psychotherapy to emerge was Sigmund Freud's psychoanalysis and his famous couch, where his patients would lay and he would perform psychoanalysis to help them relieve their unconscious conflicts. So the aims of psychoanalysis, and this is on your chart underneath aims, you can add this, but psychological problems originate from repressed impulses and conflicts in childhood, right? That's the whole idea behind the psychoanalytic theory. So the aim of psychoanalysis is to bring those repressed feelings into your conscious awareness where they can deal with them, right? When your energy that you're devoting to your id, ego, and superego conflict is released, your anxiety goes away. And that's the idea that Freud brought up in the first type of psychotherapy. So the biggest technique used in psychoanalysis would be free association. And Freud develops this method to unravel the unconscious mind and its conflicts that are occurring between the id, ego, and superego. So the patient lies on the couch, speaks whatever comes to mind. Maybe they do word association. Maybe they finish sentences, things like that. And you're not filtering your thoughts. You're just letting them come out. And that's where you identify those unconscious conflicts through that free association.
Another method of psychoanalysis would be dream interpretation. We talked a little bit about this when we got into our unit on sleep and dreams and how our dreams can be interpreted. But in a psychoanalytic, psychodynamic perspective, it's all coming back again to uncovering repressed conflicts. So dreams can reveal some of these like unconscious struggles, oftentimes stemming from childhood or experiences or deep-seated fears that we are, according to Freud, unconscious of. Right? They can provide insight into those unconscious desires. Remember back to those terms, the latent and manifest content. Well, the latent content of our dreams or that hidden meaning of our dreams can expose wishes and impulses that our conscious mind repressed. Right? You can uncover those and explore them a little bit. It also aids in catharsis, or what's known as emotional release. By analyzing and discussing the dream content, you can process your feelings and reduce any psychological distress that you may be feeling unconsciously that is trying to expose itself in your dreams. And it can also guide your treatment, right? Therapists will use this dream interpretation alongside things like we just talked about, free association, to help a patient gain some self-awareness about their unconscious mind, about their unconscious motives and behaviors, and work through those psychological issues in an effort to solve them and work through any psychological distress or disorders that may be resulting.
All right, so moving on to humanistic therapies. And the humanistic therapist aims to boost self-fulfillment by helping people grow in self-awareness and self-acceptance. And if we know anything about the humanistic theory, we know it's all centered on the self, right? Your self-concept. So you see self come up quite a bit and reaching your full potential and self-actualization. So therapists are going to help you walk through those ideas of self-awareness and self-acceptance to increase your feelings of self-confidence and self-esteem. So this is called person-centered therapy or client-centered therapy. It was developed by Carl Rogers. You're going to want to write that down on your sheet. We'll have some names for you to remember. Person-centered therapy is a form of humanistic therapy. And the therapist listens to the patient in an accepting and non-judgmental way, right? Unconditional positive regard that we know from humanistic uh, approach. So addressing their problems in a productive way and building their self-esteem, right? So that's the goal. You're restating the things that they're saying, you're understanding them, you're not judging them, and you're allowing them to help build their self-esteem in a productive way. And that's what the therapist is what they're doing in this situation is they're engaging in active listening, and they're echoing, restating, and clarifying the patient's thinking, acknowledging their expressed feelings. So it's allowing the patient to feel heard, and that you feeling as if you understand them, so that they're gaining in their self-awareness and their self-esteem, and they're feeling better about themselves because you're listening to them, and echoing what they're having to say. And you can help them work through those issues as you go. So next up, we have behavior therapy. All right. So if you want to think behaviorism, it's all about the learning principles that we've discussed through operant and classical conditioning. And that's where this is going to center around. So therapy that applies learning principles to the elimination of unwanted behaviors. So they're going to change maladaptive behavior and replace it with appropriate behaviors. That is the aim on your chart, the aim of this therapy. Change maladaptive behavior and replace it with appropriate ones. They do this. They treat phobias, sexual disorders. Behavior therapists, they don't delve deeply below the surface looking for those unconscious causes. They don't talk about self-esteem, self-awareness, things like that. They are purely action and behavior driven, right? Only observable things. So a couple of the techniques, there's counter conditioning. It's a procedure that conditions new responses to stimuli that trigger unwanted behaviors. Okay? So you're trying to unassociate those negative things that you have classically conditioned yourself to be afraid of. It's based on classical conditioning and includes a couple different types that we'll talk about. Exposure therapy and aversive conditioning are two of the biggest. So with exposure therapy, you expose patients to things they fear and avoid. Through repeated exposures, their anxiety starts to lessen because they habituate to the things that they feared. Okay, so one thing from class, an example, was Marvin when he was being exposed to that baby pit bull, right? And he was so afraid of dogs because of his history with pit bulls specifically. That was exposure therapy. They were directly exposing him to his worst fear and helping him to overcome that anxiety through that situation. This also involves exposing people to things like their fear of driving, objects in a real or virtual environment. So you don't have to do this, it doesn't have to be physically happening. You could put your brain into the virtual environment because it's really hard for your brain. It's going to react in the same way in a real environment versus virtual as well. So like a fear of flight or something like that. A type of this counter conditioning is something called systematic desensitization. And two names I want you to write down with this are Joseph Wolpe and Mary Cover Jones. They were huge in the development of systematic desensitization and overcoming these phobias and fears. So this is a type of exposure therapy that associates a pleasant, relaxed state with gradually increasing anxiety triggering stimuli, commonly used to treat phobias. So they're going to get you into a relaxed, calm state, your pleasant thoughts, you're having a good time. They're going to start by exposing you to your fear in a very non-threatening way. So for example, if you're fear of spiders, you look at a picture of a spider, right? They'll calm you back down. Then they're going to have you touch the picture of the spider, right? Maybe that's it for the first session. You come back in, they calm you down, you do those two things again, then they hold up a real live spider in front of you. You don't have to touch it, but it gets closer to you. Eventually, maybe you hold a dead spider, and then you can hold a live spider, right? They're slowly desensitizing your fear and your anxiety through different situations and trying to get you to a pleasant, relaxed state in between each example. Eventually, you won't have that fear anymore. So the other type is aversive conditioning, and this is a type of counter conditioning that associates an unpleasant state with an unwanted behavior. So with this technique, temporary conditioned aversion to alcohol has been reported, right? So one big example of aversive conditioning would be if someone's an alcoholic or struggles with alcohol, they put a little nausea drug in their drink. So when they drink it, they get nauseous, maybe they throw up, right? And so they start associating alcohol with nausea and throwing up, right? That's that classical conditioning. Same thing with someone who bites their nails. If they want to stop, maybe they'll put that some type of nail polish on that tastes terrible, and that'll get the person to stop biting their nails because they associate it with that horrible taste. So we move it on to operant conditioning here, and B.F. Skinner is a name that should ring a bell. He's the king of operant conditioning, so he's also the major player in operant conditioning therapy techniques. So operant conditioning procedures enable therapists to use behavior modification in which desired behavior is rewarded and undesired behaviors are not, or they're punished. Right? Rewards and punishments leads to a change in behavior. So a couple examples here. There's been a number of studies of withdrawn, uncommunicative 3-year-old autistic children, and they've been successfully trained by giving and withdrawing reinforcements for desired and undesired behaviors. So when they do something, like interacting effectively or communicating effectively with peers or with parents or with therapists, they're then rewarded for it and encouraged to continue doing that. And it's had big impacts on their social and communication development. So they do this through something called a token economy. So in institutional settings specifically, this is where this only takes place. Therapists may create a token economy where a patient exchanges a token of some sort that they've earned for exhibiting the desired behavior. And they get to use that token on various privileges or treats or something like that. So with the example of the autistic children, maybe they engage with sharing toys or communicating in some way with their peers or their parents or their therapist. So then they're given a reward for that, and they can use that reward to buy some type of privilege or treat. It's kind of like money in the general economy, right? But for this instance, you're trying to shape and encourage specific behaviors from those who are struggling with different disorders.
The next perspective would be cognitive therapy, right? And we've talked about cognitive approach and perspective before. Cognitive means thinking, right? So this is going to teach people adaptive ways of thinking based on the assumption that their thoughts intervene between events and our emotional reactions. So our thoughts control everything, right? An event occurs, the way that we perceive and think about that event can then change our emotional reaction or our behavior. So they want to focus on those thoughts and how they can intervene between events and actions. So for example, there's 2 ways you could respond to a lost job, right? You could have this internal belief that I'm worthless, it's hopeless, and you could fall into depression, right? Or you lose that same job and you think, my boss is a jerk, I deserve something better than this situation, and you don't fall into depression. So the way that you interpret these events that are happening to you can change the way that you feel and the emotional reactions that you have and even the behaviors that you engage in afterwards. That's cognitive therapy, change the way we think. So for example, there's a couple things to know about cognitive therapy. The first was in 1979, Aaron Beck posited the idea of cognitive triad. And he described how people with depression would think negatively about themselves, the world, and their future. And there were these 3 things that they couldn't get these negative thoughts out of their mind about themselves, the world, and the future, and they would have no hope, right? So he suggested that depressed patients believe that they can never be happy, right? That's their thinking. And thus they associate their minor events in their lives, their failings, as a major cause for their depression. And they have little control over their lives and their depression. It's kind of like that idea of feeling of learned helplessness, right? So those cognitions, such as can never be happy, need to change in order for depressed patients to recover, according to cognitive therapists, right? So this change would be brought about by gentle questioning through something called cognitive restructuring. We're going to restructure the way that you think, change the way that you think. And this therapeutic technique was used to identify and challenge negative or distorted thoughts and replace them with more rational and balanced ones. So we're going to go through your mind and figure out what disordered thoughts you're having, change them so that you can recognize them as irrational. And then based on understanding that irrationality of your thoughts, you can change the way that you interpret the events around you, right? So it's a very confrontational therapeutic approach where you're directly trying to challenge the way people are thinking, which can be tough for some people to face their negative, irrational thoughts. But this is very beneficial, right? So in 1986, they did train some depressed patients to record positive events in their day-to-day life and relate how they contributed to these events. So they're trying to frame the events in their life positively instead of negatively and how they played a role in those positive events. So compared to other depressed patients, the control group, the trained patients showed lower depression scores after training. And you can see that here in the graph, right? So these patients in the blue line who received that cognitive restructuring training, their depression scores dropped by over half, 50%, right, in their post-therapy test. While those waiting list patients, their scores decreased somewhat, but certainly not as much or as drastically as those who had received the cognitive restructuring training. So in addition to just cognitive therapy and cognitive restructuring, there's a kind of a combo therapy called cognitive behavior therapy. If you think back to what we just talked about with behavior therapy, it's kind of combining, changing the way we think, and also adding in behavioral techniques to help change the way we behave as well. So this aims to alter the way people act, behavior therapy, and alter the way they think, cognitive therapy. So first example of this would be something called rational emotive behavior therapy. And this is focused on helping people deal with irrational beliefs and learn how to manage their emotions, thoughts, and behaviors in a healthier, more realistic way. So it's kind of just taking cognitive behavioral or cognitive therapy to the next level and adding in the behaviors that result from the thoughts and emotions that you're feeling. Right. So this is a very, like we mentioned earlier, with cognitive behavioral or cognitive therapy in general, this is a very confrontational style. They directly challenge irrational thoughts to eventually change your behavior. So people who are treated with this might be someone who has a phobia, someone with anxiety, addiction, depression, anyone who they can point out their irrational thoughts, say, look, we need to change that, and that's going to help change your behavior as a result. The second example is dialectical behavior therapy. And this is designed to manage intense emotions and reduce self-destructive behaviors. Right? It acknowledges that emotions are valid experiences, but it teaches skills to regulate them rather than be overwhelmed by them. Right? So they might teach mindfulness, they might teach stress tolerance, they might teach coping skills. And that's because in a dialectic behavior therapy situation, it's more so used to treat something like borderline personality disorder. Because if we can remember, personality disorders are a lot harder to change, or they might not seem as harmful to people who have them because it's a part of who they are, right? So in dialectic behavior therapy, we're acknowledging who you are and accepting who you are while also working to change or working ways to manage your feelings and your behaviors and not allow them to overwhelm you. So some other tools to note that are used by therapists. Hypnosis is still around in terms of therapy. It has shown some effectiveness in treating pain and anxiety, but the research does not support the use of hypnosis to retrieve accurate memories or regress in age and remember the past and things like that. But it can help with some pain and anxiety symptoms. Group therapy, we saw this in our PTSD video. It normally consists of 6 to 9 people, 90-minute or so sessions, which can help more people and cost less. And clients benefit from knowing others have similar problems, right? And they're not alone in their struggle with whatever they're going through. Then you have family therapy. Family therapy treats the family kind of as a system, and the therapy guides family members towards positive relationships and improved communication in order to help with the family dynamic overall and to move through family relationships in a healthy manner or any conflicts that may have arisen that are causing issues in day-to-day life.
So the last part we need to go over is the biological therapy section. And here we just have just a normal sheet here for you with the key. It's pretty straightforward, so we're just going to stick with that and not go over any slides with you and just kind of work through them as we go. So on the back side of your sheet, biological therapy is the first one we want to touch on is antipsychotic drugs. And for antipsychotics, you're mostly just talking about schizophrenia. And those are things like Risperdal, Zyprexa, clozapine, things like that. These are meant to block dopamine receptors. They're antagonists for dopamine. We've touched on that in Unit 3, what an antagonist or an agonist does. Antagonists block receptors because the issue with schizophrenia is an oversupply of dopamine. Right? So we want to diminish that. Some potential side effects, sluggishness, tics, and other involuntary body movements. This is a very popular issue with antipsychotic drugs. It's called tardive dyskinesia. I'd make a note of that. Maybe highlight that. It's one that they like to ask you about. And the lowering of white blood cell count and weight gain. So these things are major factors in why some people stop taking their antipsychotic drugs when they're dealing with schizophrenia. So just to rewind for a second here and talk about biological therapies, right? We know that they're looking for a physical, medical solution to the issue and an imbalance in brain chemistry or something like that. So that's what they're going to focus on mostly. Next up, we have anti-manic drugs. Anti-manic, think of mania and what that's associated with. You should think of bipolar disorder, right? Lithium goes with bipolar, right? Or that's one of the most popular treatments for bipolar disorder. It's especially effective in reducing manic activity. However, lithium is very powerful, so it has to be very careful not to reach toxic levels within the blood and in the brain. Antidepressant drugs, things like SSRIs or SNRIs. We've briefly mentioned these before, but you're going to want to write this down. SSRIs are selective serotonin reuptake inhibitors. So they block the reuptake of serotonin so that serotonin floods the synaptic gap and it stays there so it can be reattached or can activate the receptors more and more so you don't have that lack of serotonin. Then you have serotonin and norepinephrine reuptake inhibitors or SNRIs. Difference is just based on the type and severity of depression that you experience. So some popular antidepressants, Cymbalta, Prozac, Zoloft, Celexa, Lexapro, things you may have heard of. Okay. Some classic side effects: dry mouth, constipation, headaches, weight gain, very similar to other side effects of these drugs, of different drugs as well. Then you have anti-anxiety drugs. These are benzodiazepines like Valium, Ativan, Xanax is a popular one you've probably heard of. These reduce the intensity of your responses to stimuli that signal punishment and frustration, or these anxiety inducing situations. They reduce the intensity of your response to those things. Usually see results within a week, but they're used for a limited time because they have serious physical dependence side effects. People can become addicted to them very quickly. They also produce lethargy, drowsiness, and reduced ability to concentrate. Right? So notice that most of these drugs don't take effect for at least up until a week, or 2 to 4 weeks, 4 to 6 weeks, because it takes time for them to build up in the bloodstream and the brain chemistry in your system. Then we have ECT, or electroconvulsive therapy. This is only used really anymore to treat severe depression. It passes electrical current through the brain via 2 electrodes placed on your scalp. It seems to reset your hypothalamus as a result, and it readjusts your hormone levels. It's not sure if this is what helps symptoms of depression or not, but it does seem to have a decrease in major depressive symptoms through electroconvulsive therapy. Only if it's resistant to all other types of treatments would they use this treatment. Okay, so using today's methods of ECT, it's a very small, limited effect on memory, but much of the public still worries about the safety and efficacy of ECT in general. And our last biological therapy is psychosurgery. The most famous type of psychosurgery, which really isn't used much at all today, was lobotomies. And this is where they would sever nerves between your frontal lobe and the centers of your inner brain structures, which would greatly reduce and change your personality, permanent lethargy, impulsive personality, immaturity. It's a very controversial thing because they didn't really understand what they were doing at the time. So psychosurgery today, there are still a few types, but they're really only used to treat generalized anxiety disorder, OCD, and major depressive disorder that are resistant to other types of treatments or all other treatments. That's the only time they'll use it. And that's because it's still very controversial and can still have some negative impacts on you and your brain overall. So that wraps up all of our therapies. We talked about biological therapies and all the different perspectives of the major therapies. We'll go back over these in class and work through them again. We've talked about a lot of different disorders. And now I've thrown at you a lot of different treatments. So we need some time to break them down. And as usual, if you have any questions, let me know.